So please, students, let's try and join so that we can begin. The earlier we start, the better. So let us join so that I'll begin. And as you join, please type in your name so that I'll know the person that has joined. Please, let's join so that we will begin. Okay, so two people have joined. Please write your name. Let me know the person that has joined. Let's begin. Okay, Bilkis Abdullah is here. So other two customers here. You're welcome. Saraj Abdullah is class rep is here. Okay. Please encourage other people to join. We need a reasonable number, at least 60% of the class. Let's have 30 something, then we start. Okay, Sharifat is here. Shuaibu Idris is there. Maimuna has joined. Mohammed Abubakar is here. Okay, Hassan Agutumu. Yeah. Okay, already we have 39 that have joined, so I think we'll begin. We'll not wait any further. So those who will join late, please do not draw us back. Mariam Mutar is here. So you will recall that we have done several lectures. We have done lectures on diabetes, hypertension, obesity, respiratory tract infection, especially chronic respiratory tract infection. These are like also these are the common causes of non-communicable diseases, which this course is about. So today we'll continue with that discussion. Okay, Lois is here. All right. So for the lectures that we have done so far, if anyone has any issue, you should write it. But if there is no issue for the lectures that we have had, diabetes, hypertension, obesity, COPD, which there is emphysema and chronic bronchitis, if you have any challenge, indicate now. And as I said during the previous lectures, um, those who have uh, or those who miss certain aspect of the lecture should go online and watch again. I'm leaving it on my YouTube page for your own benefit. So if you have missed any part, you can go there and watch it again. That's why I haven't deleted it. Okay, so if anybody, we have 38 people here, so which is a reasonable number. If you have any issue with anything that we have been discussing, please write it now. If I see five proceed without anyone asking any question, we'll proceed. So let's begin. If you're satisfied so far, you don't have any question, write proceed. And if you have any question, you write it or I proceed. This is what I will always do for the benefit of those who attend these lectures, so that if they have any, they seek any clarification, they can get it, right? So let's go. But if you're satisfied so far, okay, so Sharifat is satisfied so far, she wrote proceed, okay. One guy didn't like, he also wrote proceed, okay. If I have Okay, Rebecca Isa is here. You're welcome. If I have five proceed, I will continue, and nobody should draw me back. Laraba is here. Okay. I have four proceed. Mariam Montra also wrote proceed. Okay. I need one more proceed. If I don't see any, so let's continue. So today we are going to discuss one of the most common but hardly reported uh, non-communicable disease. That's asthma, bronchial asthma. So bronchial asthma is a very common non-communicable disease. It's seen in every part of the world, so it's not restricted to western part of western countries. It's also seen in Nigeria, and it's also a chronic it's a chronic airway disease characterized by limitation in the flow of air into the lungs. But the major difference between the chronic obstructive pulmonary disease and asthma is that asthma is reversible, meaning that if somebody is having difficulty in breathing from limitation on the flow of air, if he takes any medication such as inhaler, he gets relief and continues his life normal. While asthma is reversible, COPD is not. This is an extremely important statement, and I'll ask you in an exam. So today we will discuss asthma. Uh, some people are not stable. From 38 people here, I'm seeing 24. Please, this is class. If you're in class, do not answer calls. If not, it will be showing me here that you usually come in and go out. And sincerely speaking, if you always go in and come back, I will not record it as attendance. So if you are part of this class, stay part of this class. Don't be answering calls. Okay, so let's continue. So there are different types of asthma. And I asked that during the last year, is it last year? The last exam, your seniors. It's very important for you to have the ability to differentiate the different types of asthma. Okay, so one of the type of asthma is atopic asthma. It can be called atopic or allergic or extrinsic asthma. So atopic or allergic or extrinsic asthma. So it is the most common type of asthma. It is seen in almost 70% of people that have asthma. It is usually triggered by dust, perfumes, smoke, and other allergens or irritants. And this type of asthma usually have family history. You will agree with me that there are certain people, even maybe among you, or you have seen patients in which you see that the mother is asthmatic, the, the child is also asthmatic. So it's the atopic or allergic asthma that is associated with a family history. Okay, so and this kind of people, if you do hemoglobin E, which is the one that you see in allergy, the immunoglobulin E levels, IgE levels, are elevated. So this is one of the ways to confirm if a patient with asthma has allergic or atopic asthma. Okay, and if you do a skin test, what is a skin test? A skin test is a test that is done to check if somebody has allergy. So if you do a skin test for those individuals, you will see that they will develop urticaria, that swelling that people develop if they have allergy. So if you do a skin test for people with allergic, atopic, or extrinsic asthma, you see that they will have a lot of skin changes. We call it, they will have flare or they will have urticaria. Okay. The next type is non-atopic. You know, the previous one we say atopic. This next one is non-atopic. It's not atopic and is intrinsic. The other one is extrinsic. This one is intrinsic, right? And it's non-allergic. It's not associated with allergy. All right. So this one is intrinsic. It's intrinsic, it is non-atopic and non-allergic. So this one is not as common as the first one. Only 30% of people with asthma have intrinsic, non-atopic and non-allergic asthma. This one has hardly have family history of asthma and usually is usually triggered by respiratory tract infection. It is worthy of note that this period of Hamatan is a very dangerous period for people with asthma because they tend to have attack. So we'll discuss on what they should do. If you're asthmatic and you are in this period, please you take care of yourself. So this one, there is no allergy, there is no family history, and the IgE hemoglobin E, the IgE is normal. I will bring at least 2 to 3 questions on this to see your ability to differentiate the different forms of asthma. And the skin test, if you do it, the skin test is negative. Then the next type of asthma is called drug induced asthma. So, or aspirin sensitive asthma. This type of asthma you see in people in their older adult age. And those kind of people, if you make any mistake of giving them aspirin, they will have severe asthma attack. They will have severe asthmatic attack, right? So that's why in clinical practice, we usually write for those for those that we have confirmed that they have aspirin sensitive asthma, right on their folder. Do not give this patient aspirin. So that's the last type. It's rare, but I have seen one or two in this environment. So if you are following me so far, please write that understood, understood, understood. If you have any question, please write so that we will all go at the same pace. If you're following me so far, write understood. If you have question, please do ask. Okay. Aisha Ibrahim is here. Zainab Ardo is here. You're all welcome. Lucy Children is here. Okay, Asana wrote understood. If I get 5 understood, I continue. I will continue. Okay, I have 3 understood. Okay, I need 2. Okay, I have 4. I need one more. 1, 2, 3. I need one more. Okay, fine. So you people have understood so far. So let's discuss the mechanism of developing asthma. How does asthma come about? For anybody to have an asthmatic symptom, which include wheezing, right? Which include wheezing, cough, chest tightness, and difficulty in breathing, there has to be, first of all, a trigger. So there has to be a trigger first. And as I explained earlier, some of the triggers of asthmatic attack are dust, pollen, that means plants, that's the leaf of plants and other pollens, the perfumes, dust, then respiratory tract infection, like this period of Hamatan. A lot of people have that challenge of asthmatic symptoms. So when you have these irritants or allergens, What happens next is that the airway becomes inflamed. And when the airway becomes inflamed, there will be increased secretion of mucus, there will be spasm of the airway. This leads to limitation in the uh, the airway passage. So you have that the bronchus, the trachea, reduces in size. And when you have inflammation and constriction of the airway, what happens next is that the flow of air to the lungs reduces. So when the flow of air to the lungs reduces, the patient starts developing symptoms. So symptoms such as I earlier said, difficulty breathing, chest tightness, wheezing. So first thing is there has to be an allergen, an irritant, such as dust, smoke, strong perfume, smoke, and other things. So when these things are there, then you have inflammation, you have narrowing of the airway, and you have symptoms. So one of the triggers, apart from the ones I've mentioned, is cold weather. So extreme temperatures, like cold that we're beginning to feel now, and extreme heat. So either extreme cold and extreme heat can trigger asthmatic attack, but it's common with extreme cold. So as I explained, the symptom of asthma include cough, and one characteristics of cough in asthma is that it's dry, unlike bronchitis that I've explained in the previous lecture a week ago, right? Then they have chest tightness. They feel like that they are not getting enough air, so their chest is tight. They have wheezing, that sound that I made earlier, and difficulty in breathing. So that's how they present. But mind you, though I'm not the one to teach you heart failure, but it is very important that you differentiate this with heart failure. A lot of you, no offense to you, but a lot of you, almost 70% where you work, and we have seen cases like that, where somebody will be having heart failure and he'll be diagnosed to have asthma. Someone will be having asthma and he'll be diagnosed to have heart failure. So let me take this very, very seriously. Listen attentively. You must know how to differentiate asthma and heart failure. So let me go. For heart failure, someone must have been hypertensive or have risks for heart failure, like woman that just gave birth, there are risks of peripartum cardiomyopathy. So it may be hypertensive. Two, heart failure also present with difficulty in breathing and cough. But one characteristic of cough in heart failure is foamy, like kumpa kumpa is foamy. Secondly, in heart failure, if you listen to the chest, you will hear crackles, some sound indicating accumulation of fluid in the lungs. Then, if you check the heart, you see that the heart beat is abnormal, or the position of the heart is displaced. I know you have been taught that the heart should be at the fifth left intercostal space, mid clavicular line. So, if somebody has hypertensive heart disease, that the position of the heart will be displaced. Secondly, for people that have heart failure, if it is congestive heart failure, the liver may be enlarged and they may have leg swelling. But people with asthma, if you listen to the chest, apart from the wheeze you hear, you do not get fine crepitations indicating fluid accumulation. Two, people with asthma, they will not have displacement of the where the heart should be. And on most occasions, people with asthma should not have enlarged liver or leg swelling. So please differentiate it, because the treatment for asthma can cause danger to somebody with heart failure. So if you treat one for the other, you are likely going to kill that patient. So I hope you get some of the differences. So for the classification of asthma, asthma is classified based on the frequency of the symptoms. You will see that classification of asthma on slide 117. Please, when you should pay attention and read it closely. So asthma can be either intermittent or persistent asthma. Intermittent, they're the ones that only have monthly symptoms, while if the symptoms are weekly or daily, they are persistent. So you will see different components of the symptoms. So most patients that are asthmatic are usually at the intermittent asthma classification, unless during the harmattan, in this environment, during the harmattan, that they will start having a lot of triggers, a lot of symptoms. So people that have intermittent asthma have their symptoms monthly, and they hardly wake up with symptoms. So, and when they use their inhaler, they get relief. So intermittent, they are fairly stable. Then persistent. Persistent is divided into two: mild to moderate persistent and severe persistent. So mild to moderate persistent, they have their symptoms weekly, right? And the nocturnal awakening, that means the nocturnal awakening means asthma waking them up from sleep. They have it monthly to weekly. However, people that have severe asthma, they have symptoms daily, and almost every night they wake up with symptoms. It is important to know this difference because people that just have intermittent asthma only need salbutamol inhaler. They are fine. They don't need major treatment. But people that have mild to severe asthma, they need both salbutamol inhaler and seretide inhaler. That means the one that have long-acting beta agonist and steroid in it. I hope you people have seen that inhaler that is Psycho. It's made by GSK. Though GSK has left Nigeria, now we have another company that is producing Fortite. So people that have intermittent asthma only need their salbutamol inhaler, they're fine. But people with mild to moderate or severe persistent asthma, they need both the salbutamol inhaler and an inhaler that will prevent attack, such as Seretide. Seretide is a combination of long-acting beta agonist and inhaled steroids, steroids that is inserted into that inhaler so that they will know how to use it. Okay? So, how do you diagnose asthma? Asthma is diagnosed using spirometry or peak expiratory flow rate meter. And you can also do IgE. I told you that if you have atopic asthma, if you do the IgE, it will be elevated. During our revision, I'll make sure I bring both the I'll create a museum which all of you will see how the spirometry machine looks, and also the peak expiratory flow rate machine looks like. Okay, so but don't worry about it now. We'll see it during the revision. So if you have understood the classification of asthma, please write understood. If you have question, you ask. So as I said, we have intermittent and we have persistent. The persistent, there is mild, moderate, and there is severe. Do you have question on the classification of bronchial asthma? Please write. If not, you write proceed. If you have question, you write. If not, you write proceed. Let's go. Yeah, I said diagnosis is usually mainly clinical, right? It's clinical. So if somebody presents with, but you can do spirometry. Spirometry is uh, a test that measures the if there is any airway limitation, right? So the spirometry is better shown than discussed. So it's better I show you live than discussed. But the diagnosis of asthma is mainly clinical, sincerely speaking. So if somebody has comes to you that anytime he has contact with perfume or dust or anything, he start developing difficulty in breathing. But when he leaves the place, he feels better. And sometimes during Hamatan, that's when his difficulty in breathing comes. You will suggest that it's asthma, right? And he doesn't have hypertension. His heart is not displaced. He doesn't have leg swelling. That will suggest heart failure. Of course, he likely has asthma. And of if you get an additional history of family history of asthma, you're home and dry, right? So the diagnosis of asthma is mainly clinical. The spirometry only supports what you have done clinically. Okay, someone said it does not understand the classification of asthma. So I did not say asthma is mild and moderate. I say asthma is either intermittent and persistent. Intermittent and persistent depends on the frequency of the symptoms. Pay attention, Aminu Abdul Hamid. So the classification of asthma is based on the um, symptoms, how regular the individual have symptoms. I say intermittent, they tend to have the symptoms monthly, and asthma does not wake them up from sleep, right? So intermittent, they tend to have symptoms monthly, and asthma does not wake them up from sleep. Then you have persistent, but the persistent has mild to moderate in one class and severe in another class. So persistent, those who have mild to moderate, they tend to have symptoms weekly, and sometimes the asthma wakes them up from sleep. That's mild to moderate persistent. I gave you the major classification is intermittent and persistent. We have discussed intermittent. The persistent is divided into mild to moderate, one class, and severe in another class. So for the mild to moderate, they have symptoms weekly, and sometimes the symptoms wake them up from sleep. But for the severe, they have the symptoms daily. The severe have the symptoms daily, and every night the asthmatic symptoms wakes them up from sleep. It's as simple as that, right? So it is as simple as that. I don't know how to explain it more than that, but you see it in your notes. I have made the notes available for all of you, so you will see it in your notes. Okay. So if you see in your notes, all I want you people to take note of is the duration of the symptoms, and if that type of asthma wakes the person from sleep. Don't go down to other discussion. The only thing you add when you're reading it is the treatment. I said if it is intermittent, they only need beta agonist inhaler, such as salbutamol inhaler, Ventolin inhaler. But for the persistent, they need both Ventolin and also another inhaler to prevent attack. That's why I give you example of Seretide, that inhaler that is round, right, which contains 2 drops in it. But we don't need to go deep in this lecture concerning that. Okay, so let's continue. For okay, so if you need more explanation, please watch the video again or you refer to your note. So how do you treat asthma? As I said, the treatment of asthma depends on the severity. So first, if somebody comes with intermittent asthma, having symptoms just monthly, and not waking up from sleep because of asthma, all he needs is Ventolin inhaler. What is the use of Ventolin inhaler? The Ventolin, which contains salbutamol, what it does is that it relieves the attack. So the individual can use it anytime he has an attack. What does it do? It opens up the airway. And I told you earlier, the major difference between asthma and chronic obstructive pulmonary disease, COPD, is that asthma is reversible. So once the individual uses the Ventolin inhaler, he gets relief. So for intermittent asthma, you use the Ventolin inhaler and you are home and dry. So how about if it goes to persistent? As I said, if it goes to persistent, the Ventolin inhaler may not be enough. So you need Seretide, right? And sometimes where Seretide is not available or expensive, you can use oral aminophylline. But take note, all of you, aminophylline. Aminophylline for asthmatic patients is extremely dangerous because it can lead to arrhythmia. So if you are giving somebody whether intravenous or oral aminophylline, take note of the pulse and the BP of the individual. A lot of asthmatic patients have died because of aminophylline because it can cause malignant arrhythmia, abnormal beating of the heart, and can lead to sudden death if nothing is done. So if you're giving someone aminophylline, please be checking the pulse to know that if maybe the pulse rate has not increased or it has not become irregular. If that is the case, you stop. You stop. You do not continue. Okay. So, but the ideal thing is to give Ventolin inhaler, and if it is persistent asthma, Ventolin inhaler alone may not be enough. You need to give Sarita inhaler or that contains two drugs. Okay. So, and if it persists, you can add other drugs like the Montral, the Montelukast. Though it's available here, if you check Montral, let me just type it. Sometimes it can be added. Montral. It contains Montelukast. Okay, type in the chat. Montral. So, and the drug in Montral is Montelukast. It's not here. The drug in it is Montelukast, but the drug here is Montral, which contains Montelukast. Okay, so you can also use that. But for you, you can restrict yourself to the Ventolin inhaler, the Seretide inhaler, and this Montral, and also aminophylline. Okay. Okay, hydrocortisone, we'll go there. We don't give hydrocortisone routinely. The Seretide inhaler contains steroid in it, but we'll go to when you use hydrocortisone. Okay, so how do you prevent asthma? The way you prevent asthma, first of all, those who are at risk of asthma, you take care of them and make sure they take preventive measures so that they will not be exposed to allergies. They will not exposed to allergens or irritants. Those who are at risk of asthma, like those who have family history of asthma, right? But people that are already asthmatic, you make sure that their environment is in a way that they will not be having recurrent asthmatic attack, because people that are asthmatic that have been having recurrent asthmatic attack, for every asthmatic attack they are having, that's severe acute acute severe asthma, they tend to have reduced lifespan. Actually, for every acute severe asthma they have, their ability to live a normal life is disrupted. So we don't want it to reach acute severe asthma. I'm going to discuss acute severe asthma very soon. So for people that are not asthmatic but have the risks, you take measures on being in an environment that will limit trigger so that the inherent risks of developing asthma will not come to light. But those who are already asthmatic, you make the environment in a way that they will not have acute severe asthma. You teach them on how to take their medication the right way so that they will not have so that they will be compliant and will not have acute severe asthma. So pay attention. I'm going to discuss how an asthmatic patient will use an inhaler. I don't have one here, so it will be difficult for me to demonstrate, but I will just demonstrate. When we come for revision, I will show you. So first of all, like the Ventolin inhaler, when the patient gets the inhaler, he shakes it, right, to make sure that the contents of what is inside it is fully mixed. Then he removes the cap, right? When he removes the cap, right, he breathes in and out, right? Then he puts in the he breathes in, right, out, or better still, breathes in out. Then he breathes in and out to make sure that he has removed exhale maximally. Then he puts in the inhaler. When he press the inhaler, then he breathes in to take up the gas into his vocal cavity and upper respiratory tract. So when he takes it in, he keeps the inhaler in his mouth for 3 to 5 seconds, then he removes it. After removing it, then he waits about 30 seconds to a minute. He rinses his mouth because the steroids there can cause, especially if we are talking about the serotype, can cause oral thrush and risk for oral ulcers. So that's all. That's how you do it. You bring in and out. You know, make sure when he is breathing out, he breathes out maximally. Then he puts the inhaler. When he presses it, then he breathes in again, maximal breathing in. He waits for about 3 to 5 seconds. Then he removes it. After that, he waits about 30 seconds to 1 minute to make sure that the drug is properly absorbed. Then he rinses his mouth. Okay, so we will talk about acute severe asthma. This is the most serious aspect of asthma, and that is when you see patients come to you. Most asthmatic, you will not even know that they are asthmatic. To tell you the truth, one of my when I was doing my residency, one of my neighbors was even asthmatic. I didn't know until the day that person had an asthmatic attack. So acute severe asthma. So most of the time, you will not even know an individual has asthma until they have acute severe asthma. So what is acute severe asthma? Acute severe asthma is the severest form or acute exacerbation of asthmatic symptoms that is not responsive to the regular asthmatic treatment. I repeat, it is acute exacerbation or acute worsening of asthmatic symptoms that is not responsive to the regular asthmatic treatment, like the inhaler, Ventolin inhaler, or the Saratide inhaler. Okay, so that's acute severe asthma. So, how will you know that someone has acute severe asthma? When they come in, you will see that they have difficulty in breathing. Listen very well. And they are unable to finish a sentence in one breath. All of us here, and for those who are not asthmatic, you see that you can talk for, you can speak more than one sentence in one breath without breathing in. But asthmatic patients, when they are trying to talk, they will always they have to take in breath because they have inadequate saturation, oxygen saturation, or they have hypoxia. So they have inability to finish one complete sentence in one breath. That's one. Secondly, they have difficulty in breathing. All right. Thirdly, they have high pulse rate. Their pulse rate is 110 beats per minute and above. They also have high respiratory rate, greater or equal to 25 cycles per minute. Okay. And apart from that, right, sometimes they may have low saturation. Okay. So that's what you see if somebody has acute severe asthma. Okay. But note that there's what we call life-threatening asthma. If any person has life-threatening asthma, please, if where you're working you do not have facility for ICU care, refer the patient immediately. So if an individual have acute severe asthma, he is unable to complete a sentence in one breath, the pulse rate is 110 and above, the respiratory rate is 25 cycles per minute and above, right? And you see that he's in difficulty in breathing, having wheezing, right? You try, okay, that is acute severe asthma. But if he has cyanosis, that means the vocal cavity is blue, the hands are blue, indicating hypoxia, or if the chest is not moving, right? If he has if the pulse, he has bradycardia, the pulse rate is even going lower, and the BP hypertension is going lower, is life-threatening asthma. And at that stage, the best thing to do is, as a health worker, community health worker, transfer him to where there is availability of ICU care, which is a tertiary institution like the teaching hospital. Okay? So, how do you handle asthma? So, I will tell you how to handle asthma as someone that is working in a primary health care center. But how many of you have nebulizer in where you're working? Please indicate. If you have it, you write yes. If you do not have it, you write no. How many of you have nebulizer where you're working or where you have worked? Please write it so that I'll know the kind of discussion I will do. How many of you have nebulizer where you're working? How many of you have nebulizer where you're working? Write it down. Okay, Pfizer said no. Okay. Wow, majority are saying no. So, okay, wow. Does even anybody has used nebulizer? Wow. So nebulizer, as some of you that have done AIE posting, you have seen it, is okay. Abila say yes, very okay. So nebulizer is a system of delivering salbutamol through a max, right? Because during acute severe asthma, salbutamol, oral salbutamol, or as inhaler will not be enough. It has to be nebulized salbutamol. So it is just you deliver it through oxygen max. I think during our revision, I'll also bring it for you people to see. There is no way you will be treating acute severe asthma without nebulizer. You will not get result. And that's why most of you resort to using aminophylline. But nebulizer is faster, better, with less side effects. Okay, so usually the nebulized salbutamol, they come in ampoules. You put it inside a chamber and the person puts it like a face mask. You on the machine and the person will be inhaling the gaseous salbutamol, and that will open up the airway of that individual. So in acute severe asthma, when they come to your PHC, first of all, check their pulse. If it is more than 110, it's acute severe asthma. Check their respiratory rate. If it's more than 25, it's acute severe asthma. Check their oxygen saturation. If it is low, you give them oxygen. Right? The next thing you are supposed to do is to give nebulized salbutamol, as I explained. But if you do not have it, you can give aminophylline. But note that if you are giving aminophylline, it's best under ECG monitoring. But most PHCs don't have ECG. So what you are going to do is that as you are giving it, you'll be checking the pulse, you'll be checking the BP, so that if the patient is at risk of malignant arrhythmia or abnormal beating of the heart that can lead to death, once you are checking, you see the pulse is increasing or the pulse is becoming irregular, then you stop, right? But if that the problem is not there, you continue. So if you do not have nebulized salbutamol, you can give the individual aminophylline. Then next you give hydrocortisone. Hydrocortisone is important because it reduces the airway inflammation seen in acute severe asthma. So you give hydrocortisone. And if the trigger is respiratory tract infection, you give antibiotics. So it's expected after doing all these things, oxygen, nebulized salbutamol or aminophylline, depending on what you have, hydrocortisone, and antibiotic if there is respiratory tract infection, the patient should get better. But once the patient is getting worse, evidenced by uh, the pulse going down, you have bradycardia instead of tachycardia. If the chest is becoming silent, no chest movement. If the patient is becoming to is now having hypotension, it's a danger sign. We call it life-threatening asthma. You quickly refer the patient to a tertiary healthcare center for intervention to be taken. Okay, so this marks the end of discussion for asthma. Sincerely speaking, you all should work hard to have you have it's very important for you to have a nebulizer where you're working. Do you know that some individuals have nebulizer? They are small nebulizers that cost about 60 to 100,000. So you cannot treat asthma in any facility without nebulizer. So let me have questions. Any question on asthma, please go ahead. Tomorrow we'll discuss cancers, and that will be the end of our lectures. So that next year we'll do revision of, and that will be in the class. So let's ask questions on asthma. Nobody should go with question on asthma. Don't go and destroy the life of any patient instead of treating. So you need all the information that you need. Okay. So questions on asthma, any aspect of asthma. Is it the classification of asthma, the types of asthma, the treatment of asthma, or acute severe asthma? If you have any question, please do ask. Okay, I'm waiting for those who have totally understood the lecture, just type understood. But for those who need to further explanation, you please write down so that we'll do our regular questions for we'll do our regular question and answer for the day. So because as I said, the question and answer that I usually do is likely what will come in the exam. So for those who usually leave this lecture before question and answer time, I don't know what to say. Okay, all right. So Umar Gombe asks, is asthma curable? It's not curable. There's no cure for asthma, but it can be managed just as diabetes and hypertension. They can be properly managed and you have remission, no attack. But if you go back to doing what you like, exposing yourself to strong perfumes and other things, your asthma will come back. Okay, so Sarajo has more clarification of type of asthma. See, type of asthma is very simple. You have allergic allergic asthma, and allergic asthma can also mean atopic asthma or extrinsic asthma, and you have non-allergic asthma. We said that allergic asthma is the one that have family history, is the one that have IgE, immunoglobulin IgE elevated, is the one that is usually triggered by dust, smoke, pollen, and other things, right? And we say the non-atopic or the intrinsic asthma is less common than the allergic asthma. And that type of asthma is not associated with family history, and the IgE is normal. So if you check your note, you will see the table. I did it. You will see the differences. I tell you the truth. I'm going to ask it. There's no way I will not ask it. Is on slide 112. So it is very important that you know that. Okay. Then someone asks examples of antibiotic to give given. So antibiotic for upper respiratory, depending on what you're thinking, but the general antibiotic is the amoxiclav, augmentin, but you can also give cefuroxime like Zinat, right? But if the patient is bringing out sputum, it is very important that you ask for sputum MCS, culture the sputum to know the antibiotic that is most sensitive, right? But you can start with augmentin or Zinat. That's amoxiclav or cefuroxime. Okay. I said diagnosis of asthma is clinical. So if somebody has family history of asthma and anytime is exposed to dust, to smoke, to perfume, they start having difficulty in breathing. And sometimes it wakes him up from sleep. And you see that the patient does not have hypertension, does not have leg swelling, does not have any problem with the heart, likely he has asthma. Nobody has to tell you that, right? But you can confirm by sending a test uh, to, to, to the specialist in the teaching hospital to do spirometry, but it's mainly clinical, all right? So that's the diagnosis. The diagnosis of asthma is mainly clinical, but you can do spirometry to confirm. Sometimes for patients that have intermittent asthma, even if you do the spirometry, it will be normal. That's why I said the diagnosis of asthma is mainly clinical. Okay, so Abila asks, a patient presented a picture with acute severe asthma and you use nebulizer and no improvement. Can we use fluid for the patient with aminophylline into the drip? Yeah, you can use aminophylline. If you give nebulizer, you're supposed to give nebulizers at least repeatedly 3 times. If you see that there is no improvement, you can give aminophylline. But if you are going to use aminophylline in drip, it has to be very slow, and you should be monitoring the pulse and the BP. So, but as I said, as you're doing this treatment, if you see worsening of the saturation, you see that the pulse rate is going down, the BP is going down, quickly refer the patient to the teaching hospital for proper management by the pulmonologist. Okay. So, Nuruddin asks for more light on life-threatening asthma. Life-threatening asthma is just showing you that there is danger. There is danger. And if you see that the saturation, oxygen saturation is going low, if you see that instead of the pulse rate to be high, it's going down, you have bradycardia. If you see that the BP is going down, if you see that the chest is not really moving, it's showing you that it is life-threatening asthma. You quickly refer. But if you sit on a patient with life-threatening asthma, that patient is going to die for you. Or when by the time you decide to refer the patient, it might be too late. All right. Okay, I hope I've answered all your questions. Is there anybody that have skipped this question? Please ask. So if you need more explanation, please watch this video again, especially the things I have discussed, because someone write more explanation on explanation of asthma clinical diagnosis. I just said it. I don't need to repeat myself again. If you need, I've said it like twice here. So if you need, uh, you need to watch this video again. Then you watch it. Is it allowed to dilute hydrocortisone with aminophylline? No, 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 no. Please do not mix aminophylline and hydrocortisone are administered at the same time. Please do not do that. Give hydrocortisone separately. You can start with 200 milligrams start, then subsequently you can be giving 100 milligram 8 to 12 hourly. But do not mix hydrocortisone with aminophylline. Please do not try that. If you have been doing it, stop it. Okay? What is the complication the person will have with asthma develop? One of the complications is respiratory failure. So if the patient develops respiratory failure and nothing is done, the patient can die. You can also have arrhythmia, heart problems, right? Arrhythmias. And arrhythmia can also cause death in people that are asthmatic. So as asthma is something that people can live normal with it to their 80s if everything is done to avoid attack. But if they are having frequent acute severe asthmatic attack, then their chances of living that long may be affected. So if any patient is resistant to anti-asthmatic drug, please refer the patient to the pulmonologist. The pulmonologist will decide which is the best drug for them. If anyone is not responding to your Ventolin, is not responding to your Seretide, you added aminophylline is not working, you added Montral is not working, please refer the individual to the pulmonologist in the teaching hospital. Then someone has azithromycin. Azithromycin is for atypical organisms that cause respiratory tract infection. So if you're suspicious that this is not the regular pneumonia or upper respiratory tract infection, you can add it. But to be more specific, the best way to treat asthma, if you think the best way to treat asthmatic attack, if you think the trigger is from respiratory tract infection, is to do culture. Ask the patient to produce protein, culture it, know the organism, and the best way to treat it, isn't it? There's first aid. No, in asthma, there is no issue of first aid now. If somebody, I told you, if somebody comes with asthma, right, you assess, the pulse, the BP, you assess the respiratory rate, you check the oxygen saturation. If it is acute severe asthma, you start treating, right? By giving nebulized salbutamol. If you don't have it, you give aminophylline. You give oxygen to the patient. You give hydrocortisone. And if you think the trigger is infection, you give antibiotic. But if the patient is not improving or the patient is lapsing into life-threatening asthma, you refer. It's as simple as that. Do not keep patient. One of the best way you show yourself as a good health professional is knowing your limit. Any health professional who does not know his limit is a very bad health professional and he is dangerous to the patient because most health professionals who keep patients longer than necessary have been found to kill more patients than those who know their limit and refer. So when you have done your best and there's no response, refer the patient. There's no reason for you to keep patient longer than is necessary. So the preventive measures is avoid trigger. If someone is asthmatic, you teach the individual how to avoid trigger. So like this Harmattan period, make sure he wears a cardigan, right? Or something that keeps him warm. Make sure whenever he's going out, whether he's riding a bike or he's going out, since it's Harmattan, he uses face masks. Because once he's irritated by the Harmattan dust and other things, he will come with acute severe asthma, and you teach the individual to be compliant with using inhaler, that he should not be skipping his inhaler. As I said before, Ventolin inhaler is for when he has attack, but Seretide inhaler is to prevent attack. So the Seretide inhaler should be used every single day to prevent attack, while Ventolin inhaler is when he has attack. So when you teach him on compliance with his medication, avoiding trigger, and whenever he has a respiratory tract infection, you should come to the hospital and treat it. I think that individual with asthma should be fine. Okay, so any more questions? Any more questions? If there are no questions, you type thank you, sir. If there are no more questions, type thank you, sir. If there are questions, you write it. I hope I have answered every single person's question. No one should go with any questions. Okay. So I'll answer. Classroom, do we have time for question and answers, or the next lecturer is here? Please let me know. Is the next lecturer here, or we have time for question and answer? Class rep, I'm waiting for you. Is the next lecturer here, or we have time for question and answer? I want tomorrow. I want us to just start with. Okay, so the next lecturer is not here. So if you are ready for question and answer, please type proceed. If you are ready for question and answer, please type proceed or ready, sir. Either type ready, sir, or proceed. Let's answer some questions. Okay, so I've seen proceed. Okay, so question one. Question one. Okay. Question one. The following are types of asthma except. The following are types of asthma except A. Atopic asthma. B. Non-allergic asthma. C. Drug-induced asthma. D. None of the above. Okay, or let's change the D. D. Liver asthma. So the following are types of asthma except allergic asthma, non-atopic asthma, drug-induced asthma, or liver asthma. Okay, so D. So the ones I've mentioned. Okay, so question two. Very good. So question two. The following are characteristics. Question two. The following are characteristics of atopic asthma except. The following are characteristics of atopic asthma except. A. There is family history. B. Is triggered by allergens. C. The IgE is normal. D. None of the above. Okay. So the following are characteristics of allergic or atopic asthma. A. There is family history. B. is triggered by allergens. C, the IgE is normal. Then D, none of the above. So which one is not occurred? Very good. So other two, the IgE is normal. So in allergic asthma, the IgE is elevated, right? Very good. Okay. So let's go. Number three. Number three. The following are classification of severity of asthma except. The following are classification of severity of asthma except A, intermittent asthma, B, mild to moderate persistent asthma, C, severe persistent asthma, D, acute severe asthma. So the following are classification of severity of asthma except A, intermittent asthma, B, mild to moderate persistent asthma, C, severe persistent asthma, D, acute severe asthma. So which one is not in the classification of the severity of asthma? Okay, let me see the answer. Are you people there? Yes, other two. Very good. So acute severe asthma is on its own, is the severest form of asthma. It's not part of the regular classification of asthma, right? Very good, very good. Okay, very good. Acute severe asthma, very good. So next, which of the following is not a characteristics of acute severe asthma? Next, which of the following is a characteristics of acute severe asthma? A, pulse rate of 90 beats per minute. B, respiratory rate of greater or equal to 25. C, inability to complete a sentence in one breath. D, none of the above. So which of the following is a characteristic of acute severe asthma except, I say A, pulse rate of 90 beats per minute, B, respiratory rate of greater or equal to 25, C, inability to complete a sentence in one breath, then D, none of the above. Which one is not characteristics of acute severe asthma? So which one is the answer? I gave you the things that you see in acute severe asthma. So which one of the ones I've mentioned is not there? Okay. Which one? I said A, 90 beats per minute. That's the pulse. B, very good. So other two. So 90 beats per minute is the wrong one, right? The pulse should be greater or equal to 110 beats per minute. So 90 beats per minute is the wrong one. Very good. All right. So we have come to the end of this lecture. If you have any question concerning anything that we have discussed about asthma, please ask. If not, please write thank you, sir, so that we'll conclude. If you have any question, you ask. If not, write thank you, sir, so that we conclude. Okay. All right. So thank you, Mariam Mutar, for coming. Okay, Abila, also thank you. Hajara Ibrahim, thank you for being part of the lecture. Umar Gombe, Thank you for being here. Okay. Anyone that has questions should ask. Okay. Sarajo, thank you for being here. Maimuna Salihu, thank you for being here, for joining the lectures. Hope you people had a great time and you understood what you have been taught. Okay, Saada too, you have been very active today. Thank you for joining. Faiza, Akis Abdullahi, thank you for joining. Hassana, also very active. Kolo, also very active. Thank you for joining. Thank you all for coming. Uh, all right, Memuna also always active. Thank you for being here. Okay, so all of you have a wonderful day. Tomorrow we'll begin, Abila, thank you for joining. We'll begin with um, cancer. We'll discuss cancer. I will conclude the lecture for this course until maybe after the break when we'll start physical revision. Okay, someone asked, salbutamol tablets can be used instead of the Ventolin inhaler or the salbutamol inhaler. The tablet can also be used where the inhaler is not available. Even sometimes where we don't, the pulmonologists and us as specialists, we don't like giving oral prednisolone. They do not advise oral prednisolone again for asthmatic patients. But we'll discuss this more in detail when we come for revision, when I bring the inhaler to demonstrate things to you. Have a wonderful day. Have a nice day. Bye bye.